Hi, PsychU community. This is Dr. Jackie Canning, Medical Science Liaison here. And today we're coming to you with part 2 for viruses, vaccines, and long-term consequences, perspectives on SARS-CoV-2 Mythbusters edition. So this is a continuation from the program that we did last year. You should have already watched part 1, hopefully, and now we are going to do part 2 of that continuation. So today our featured speaker is Dr. Gary Pattee. You may recall he did that first set of recordings for us, and he's a clinical neurologist from Neurology Associates and is also an assistant professor and clinical instructor for the Department of Neurology and co-medical director for the Muscular Dystrophy Association Clinic within the University of Nebraska Medical Center. He also serves as a clinical instructor in neurology for the Lincoln Family Practice Residency Program. He has extensive experience conducting preclinical and clinical trial research, as well as hundreds of scientific publications, abstracts, and oral presentations. This program is paid for by Otsuka Pharmaceutical Development and Commercialization and Lumbach LLC. I am an employee of Otsuka, and Dr. Pattee is a paid consultant. So the rules of engagement here are that this is intended for educational purposes only. This is not for individual patient recommendations. There are no CME credits assigned to this, and we will not be addressing any specific medications during this presentation. So our objectives today are to differentiate the myth related to the pandemic, discuss common misconceptions related to the reinfection of SARS-CoV-2, and review frequent falsehoods surrounding SARS-CoV-2 vaccines. So, Dr. Pattee, I am really interested to hear your take on some of these myths and some of these most persistent and dangerous myths. Let's just tackle those first. So, do you want to walk us through some of these?
Well, happy to. Thank you for the kind introduction, Jackie, and thank you for those joining us today. The myths behind this virus, as the title suggests, can at times be very dangerous. So we're going to go through some of the more common ones. Some of these were just found online that we decided we wanted to address and bring to the attention and at least try to explain them if at all possible. And we'll go through the points individually. First, the novel coronavirus is no worse than the flu. Well, I think we've all understood that that quite likely is not the case. And let me use a good example I'll use with my patients. Here in Nebraska, I have a lot in the farming community, and skin cancer is something that they see a lot of. And our patients may present with a basal cell carcinoma, squamous cell carcinoma on their face, nose, or ear. Fairly benign, doesn't have a big impact, but it is a skin cancer. Then there'll be one or two that'll present with a melanoma, which is also a skin cancer, but far from being benign. I use that example that this coronavirus is like the melanoma of flu viruses. It is unpredictable, it can come and go, and we don't always see it, and it can take you out. And so the comparison between this virus and the flu couldn't be broader, in my opinion. Point 2, you don't need to wear a mask. Now, this is a changing landscape. This particular slide was made a few months back at a time when it was required. Then earlier this month, it seemed to be lax, but now we're seeing the CDC suggest indoors it quite likely is still important. I think that it still makes sense. Simply put, in our office, everyone wears a mask. The hospitals, everyone wears a mask. It still provides our first line of defense. Point 3, hydroxychloroquine is an effective treatment. Well, the myth behind that is that it simply has not been shown to be true. There was a large study performed, which was referenced by the World Health Organization, called the Solidarity Study. And in this study, they used 4 different drugs. They used hydroxychloroquine, beta interferon, remdesivir, and a combination of monoclonals, lopinavir and ritonavir. And all 4 of these agents were used in COVID populations to see if it had any impact on the morbidity and mortality. And the study was stopped because it had absolutely no impact. All 4 drugs were not shown to be effective in that particular study. Furthermore, other studies focusing on hydroxychloroquine have not shown it to be effective, although it has had some other consequences, cardiac consequences in particular. So it is not recommended as a therapy at this point. Point 4, spikes in cases are because of increased testing. Well, that's not necessarily true because right now there isn't that much testing being done, number one. About 1 in 10 cases that we're seeing that are positive are usually in a hospital setting. Most people that test themselves do so at home, so we really don't have any way of seeing it. But the spikes in cases have to do with hospitalizations, and that's what people don't quite understand. And you can watch the news every night, and it shows how many local hospitalized cases there are. And those are not because of increased testing. Those are because of increased infectivity. Point 5, we can achieve herd immunity by letting the virus spread through the population. Well, simply stated, that comment is true, but it really is important to put it in perspective, and that's the last point versus vaccination. Meaning, are we going to achieve an immunity as a population based on letting the virus spread or becoming vaccinated against the virus? And I think that's the real key issue. We've seen from our colleagues in Sweden that achieving herd immunity has a toll. And the toll is going to be the underprivileged, the people that have medical consequences, the elderly, and a lot of individuals who had no clue that this virus would do what it did to them. So I think most medical providers do not believe in the achieving herd immunity by letting it spread, but it can safely and more, I think, healthfully be addressed through the vaccination process. Next point, any vaccine will be unsafe and a bigger risk than getting COVID-19. Well, there's been a lot documented on these vaccines, needless to say. We've seen some complications with all the vaccines, yet when we put it in perspective, and that's something that I think is always important to do, you look at what the infection can do to an individual, and one of the key worries we have would be cardiac involvement. 50% or more of patients who are infected with COVID have some sign of cardiac involvement, possibly elevated troponin when they're in the hospital or when they first present, or some effect on their ejection fraction later on. Whereas with the vaccines, we are seeing some reactions, but most of these are extremely rare. And some of the ones that come to mind have to do with the vaccine-induced thrombotic thrombocytopenia, this VITT that we saw with the viral vector-based vaccines, where clots within the central venous thrombus, basically with sagittal sinus, different sinus thrombus in the brain, were occurring. Patients were presenting with headaches, seizures, various issues, and there were about 8 cases reported, but out of about 7.8 million exposures. So the ratio was 1 to 1 million, an incredible odd against having that happen to one. We've also seen in other countries that the risk of myocarditis with the vaccine is about 23 per 1 million. So when you look at that risk versus the risk of what the virus itself can do to the body's organ systems, the safer choice is still the vaccine. The novel coronavirus was engineered in a lab in China. Well, that was kind of the hoopla initially given to us a year ago. And it now is being looked at because right now I don't think we know where this virus came from. The Biden administration in late May organized a panel, gave them a 90-day window to try to identify where this virus came from. Some people think it still has a animal to human transmission. Some think because of the coding of it genetically that it must have been man-made. But the jury is still out on this point. Second to the last point, which I found incredible, wealthy elites intentionally spread the virus to win power and profit. This was something we saw online. I'm trying to understand scenarios where this might be true. Apparently, this is something that was propagated in some of the poorer countries, and there probably is some truth to that in terms of that being tried. But that is certainly, the virus is real, and people will try to give misinformation about the virus to win power and profit. But this virus spreads regardless of political leaning or whether you're wealthy or not. And I think the key issue here is you've got to know who to believe when you seek out information on what this virus can and does do. The last point has to do with the Black Lives Matter protests. And I think my comment here is that this is not a political virus. It doesn't care what side of the aisle you're on. It will afflict everyone. We know that large groupings of individuals can lead to increased transmission, but the key is it's not a political event, and certain I guess movements do not seem to have a pattern of spreading the virus. So it once again doesn't hold any water. It is important, however, to remember that it is, at least with the new COVID-19 Delta variant, it's a bit more readily transmissible now. So larger gatherings of people we're still sort of trying to limit. Yet my fears are this fall, as the football stadiums fill with individuals, and I think Jackie can attest, some of the spring break beach parties in Florida, this is anytime you get gatherings of people, that risk does certainly exist. But it's not a political movement per se that increases transmission.
I agree, and you're right. When gatherings happen, it definitely does increase the risk of transmission. We saw that in Florida during spring break. You're seeing that in large gatherings in sports stadiums, et cetera. So I think it really just makes a difference if you're taking proper precautions, wearing a mask, et cetera. And I think that something we're also going to come back to throughout this entire presentation is that we're learning about this virus as we go, unfortunately. And we just don't know things until we've had enough time to study them and research and really gather the data. So some of this stuff changes as we learn. So example, the mask mandates and wearing a mask. Essentially, we came across having to have a mask on all the time. Once vaccinated, it was recommended. Once enough data was collated to not wear the mask. And then now, given the new variants and new data that's come to light, wearing a mask again is now recommended in those areas. So just trying to understand that as data changes, these recommendations change as well. So some common COVID myths dispelled. There are a lot of other ones going on, and I do think it's really important to kind of weed through some of these. You want to go ahead and give us some discussion around these here, Doctor?
These are the points of reality. So point one, this virus is caused by a virus, this disease, not a bacteria. And as most people, I think, tuning in today understand, viruses and bacteria both are infected, but totally different organisms. Therefore, antibiotics cannot prevent or treat COVID-19. Point two, people of all ages can be infected. And we've given a talk already showing that young children can be infected, elderly people can be, middle-aged people can be. There is no protection based on age, yet elderly seem to have a higher risk of becoming infected. Everyone, however, is at risk. Point three, most people who get the COVID have mild or moderate symptoms and can recover thanks to supportive care. Catching the COVID does not mean you'll have it for life. So there's certainly some truth in it. The problem is we don't know who that is, obviously, who will be taken on a milder course. And just because you caught the virus, it doesn't mean you're going to have infection from the virus. I think that's important to emphasize. Now, you may have antibody response in your blood for an extended period of time, but it does not mean that you will have symptoms or worsening of symptoms as time goes on. So it's like any virus, it does its thing, and then with time, most people do heal. The question is, we don't always know how long it takes to achieve that. And point four, the prolonged use of medical masks when worn properly does not cause CO2 intoxication or oxygen deficiency. As a physician caring for patients with COVID in the ICU, we have our PPEs on, and we actually do just fine. These masks do not limit your ability to breathe. Having just gone off an international flight with a 9-hour mask, I can attest to the fact that I didn't have any of those issues. So this does not occur. These masks are safe, and they're our best first line of protection.
And I think that sometimes we don't realize or we forget that regular mask use happens, such as in surgery and ERs and in places where reducing infection is extremely important. So a surgeon may wear a mask for many hours during a long, complicated surgery, and it doesn't affect their cognition or CO2 levels, et cetera. So I like to remind everyone that this isn't new to wearing a mask all day. It's just more generalized now.
Well, and Jackie, absolutely. If we look at our burn units, we have a very active one here in our town. The nurses are always having masks. They have to. These patients are at risk otherwise. So it's exactly as you stated. The mask itself does not cause physical harm or health risks to the individuals wearing it. It's usually just the opposite, that they prevent the spread of viral transmission to those around them.
Mm-hmm. Exactly. So let's actually talk a little bit more about that, some of the myths surrounding what spreads or detects COVID. So what stands out here for you, and what are your thoughts on these?
Well, this is a great slide. I just think it's one that it's important to just look at point by point. So the likelihood of shoe wear spreading COVID-19 is very low, as well as transmission from other surfaces. Earlier on, we were seeing this virus exist on surfaces for many, many days. But in terms of transmitting it to someone and infecting people, that just never really panned out. The same thing with shoes. Now, there's a lot of dirt on our shoes, especially if we're walking through hospitals. So I'm not advocating wearing your shoes in your home once you enter, but I don't think the worry, which initially was high, that we're going to have COVID from the shoes is going to happen. Just as an aside, as a medical student in the 1980s in Houston, we worried whether AIDS would be transmitted through sweat. And so there was a lot of worry about that transmission, which didn't turn out to be true. So with time, we're realizing how this virus actually is spread. And this is predominantly a respiratory transmission. Point number 2, COVID is not transmitted through houseflies or mosquitoes. I guess the only confusion there would be with the West Nile issues. And so, no, we're just not seeing this transmitted through small vectors like that. Point 3, water or swimming does not transmit the virus. I think that's an important point. Point 4, one that still amazes me, 5th generation mobile networks do not spread COVID. This was a big issue in the UK for a while early on. How it got spread on internet, I have no idea, but there's nothing to stand behind it. There's not a shred of evidence to suggest it. And then the last point, thermal scanners cannot detect COVID-19. That stands alone. It just doesn't work. So these are just some of the myths. There's a lot of them out there, I'm sure. But I guess the most important thing is people should seek out questions to answers to questions they may have that don't necessarily fit. When you don't know all the answers, it's easy to I suppose, make up scenarios that might be concerning. But these and others have never shown to be true.
Absolutely. And I do think the thermal scanner may have come about from just the temperature raises in those individuals when they first become sick. But someone can have a temperature from anything, and not necessarily being able to detect thermal scan as it was being called doesn't necessarily mean that you don't actually have a COVID infection either. So I do think that's important that you discuss that. So let's talk a little bit about what prevents COVID and some of those myths that have really been prevalent during this time.
Yeah, so in the first I've kind of talked on, the clinical trials confirm that hydroxychloroquine, Plaquenil, the chloroquine, several different agents that they use, same base compound, does not prevent illness or death from COVID, nor does it show clinical benefit. And I think the reference to the Solidarity study was probably the most important. There was a study by some individuals at the University of Penn, I think it was called the Pattee study. It was also stopped because it didn't really show benefit. And I think that's been pretty well documented that this particular agent is not meant to be used in treatment. Now, we'll have anecdotal cases of any compound, this being one of them, where some individuals took it and they thought they improved. And I guess as a scientist, I always say that an N of 1 is not data, and that we need to do trials to investigate the efficacy of these compounds. And so far, it has not panned out. Point 2, vitamin and mineral supplements cannot cure COVID. Well, there's a lot of emphasis on holistic medicine these days in every realm. Vitamins help. I'm certainly a fan. We'll talk about those a little later on, but they cannot cure this particular virus. Now, adding pepper to your soup or other meals does not prevent or cure COVID-19. And I don't know, Jackie, the history behind this assumption. There's something behind it apparently online, but I medically and even scientifically, I'm not quite understanding how that would even work or make sense. If you have more to add, feel free. The next point, hot bath does not prevent a SARS-CoV-2 infection. Getting back to what you had alluded to, that the heat is not something that actually will prevent these infections. In fact, when the body warms up after an infection or even after a vaccine reaction, it's the natural immune process. It's what we expect to see. It's what should happen, in fact, to activate our immune system to fight off foreign agents. But in this case, a hot bath does not achieve it. Hand dryers are not effective at killing the COVID-19 virus. There's nothing that says that you can use a blow dryer to kill it. So I think that's important for people to realize. UV lamps should not be used to disinfect hands, skin, any part of the human body. UV lamps have been used to sterilize masks. In fact, early on, that's how mask sterilization was taking place, so that we didn't throw away all of the N95 masks. We could use them over again. But it's not to be utilized on human tissue. In fact, that can lead to DNA damage and a lot of other skin disorders. Last point, vaccines against pneumonia do not protect against the COVID-19. That's absolutely true. Pneumovax, these different vaccines out there, have no effect on this particular coronavirus infection.
And I think some of these arose from just home remedies where individuals were trying to find anything to help them prevent the spread and keep from getting infected, especially when many different types of disinfectants were becoming in short supply or unavailable altogether. So I do think people were just trying different types of home remedies, anti-inflammatories, anti-infective types of things that may have had some basis in some other areas. I do think that's how some of these arose.
Yeah, and these were online concerns. So these aren't these. I think that's the importance of pointing them out, that a lot of people don't have good information on these points. So it's good to discuss and to talk about it.
Absolutely. So let's keep on with this theme. Let's talk a little bit more about those myths surrounding what prevents COVID infection.
Yeah, so rinsing nose with saline does not prevent infection, nor does eating garlic. So garlic is used by a lot of people as sort of somewhat of an antioxidant, but it's not been shown to be effective against this virus. I think the thought that if you can clean out or neutralize the isotonic nature of the nares within the nose, you're not going to get infection, simply not the case. This virus loves the nose. It's cool. It loves to live in the nostrils. And like so many viruses do, and rinsing may help treat an upper respiratory infection with congestion. It does not prevent infection. Spraying and introducing bleach or another disinfectant into your body will not protect you against COVID-19. And maybe the most important thing, it can be horribly dangerous. So there's no place for bleach or disinfectants to be taken internally in any scenario. Point 3, drinking methanol, ethanol, alcohol, or bleach does not prevent or cure COVID. I think it pretty much emphasizes the same. You can't just take a shot of whiskey, for example, and expect to kill the COVID in the back of one's throat. This is not what happens. These viruses get into the cells themselves and live within the host. They're not just hanging on to the skin, so to speak. Point 4, exposing yourself to the sun or temperatures higher than 25 degrees centigrade does not protect you from COVID-19. And this is true. There's nothing about heat that can have an effect. In fact, COVID virus can spread in hot and or humid environments. Cold weather and snow cannot kill the virus. So what you put your body under in terms of temperatures, high or low, really has no effect on the virus within you. Being able to hold your breath for 10 seconds or more without coughing or feeling discomfort does not mean you are free from COVID-19. And I think that speaks for itself. I don't think there's anything about that statement that needs to be commented further on. I'm not totally clear how that came about, but there are no home remedies, as Jackie was suggesting, that have been shown to be effective in terms of curing this virus.
And I think some, individuals were just looking for some way to try to use home remedies like we had talked about before. Alcohol use went up dramatically during this pandemic, and we would like to hope it was all because of disinfection, but I do think some of it was definitely mental health related and coping related. So maybe used as an excuse slightly. And then being able to hold your breath, some were indicating that that was a sign of continued good pulmonary function. And because there was so much on the news about decreased pulmonary function and individuals being in the ICU, I think that's where that one arose. But there's no clinically significant data that indicates 10 seconds means anything, or the fact that it doesn't mean you're not currently infected. So let's transition to vaccines. So vaccines have been an area with many myths surrounding them. And let's talk a little bit about these here and try to clear up some of them.
Well, no, this is a very important point, I think, Jackie. And just to get started, the COVID-19 vaccines involve new technology some of the RNA techniques, as we know, and were developed quickly. But it's not because there were shortcuts in the process. So the Operation Warp Speed that got this jump-started last spring of 2020 got a lot of the companies working on vaccines. And I would argue, even though they were developed quickly in terms of the history of vaccine production, it wasn't from shortcuts. And in fact, so much scrutiny has been paid to the whole developmental process. I don't think in any other time we've had more eyes watching how things are done, that shortcuts simply would have been spotted and recognized and would not have worked. So that's what makes this so amazing, in my view, that we're able to get these vaccines developed, and they're developed and working so well. I mean, look at the efficacy of the vaccines that have been approved. 90-95%. It's almost unheard of to have several actually achieve that level of efficacy. So I think it speaks to the technology involved. It also states that these shortcuts were certainly not taking place. I will mention once again that these are emergency authorization by FDA, meaning there hasn't been time for the FDA to fully process requests for what they call full licensure. But I'm confident that will happen, and most regulators think it likely will happen by the end of the summer or early fall, that one or two or more of these vaccines will undergo full licensure. And not because they don't think it's safe. If that were the case, they would have been pulled off by now. But because there has to be labeling, there has to be how to store these vaccines in place. All of the other sort of important secondary measures have to be fulfilled before they can provide the full licensure. Point two, it would still be appropriate for someone to get the vaccine to ensure protection, even if you've had COVID-19. So this is an interesting point, one we could probably talk about for a while, and that is, if you've been infected with COVID, do you still need to have the vaccine? Well, just to hit the highlights. Individuals infected with COVID produce their own antibodies, certainly, but the question is, how long do these antibodies last? Some of the more recent data that I've seen suggest they can last anywhere from 6 to 8 months, sometimes longer, sometimes shorter. Seemingly, the more severely one is affected, the longer the antibodies last. Some early UK studies suggested with mild infection, antibodies were gone within 3 months. So that's why they're waiting typically 90 days after an infection before a vaccine is offered. And getting back to some of the issues with the vaccine that we focus on is these vaccines are focusing on the spike protein, which is, the vaccines, at least the injectables, are in the muscle. The immune system has a chance to really focus on that spike protein itself, in what's called the receptor binding domain, so that a range of different protective mechanisms are in place by the vaccine to protect against reinfection. Natural infection, however, looks at the entire virus, and oftentimes it's in the lung. It may not have as much time to scrutinize what area it's going to develop an antibody to, but if it's not focusing on the spike protein, the docking protein, probably the rate-limiting step in infectivity, then it may be falling short. So those have been some concerns. Now, the other side of the fence, they've looked at some of the memory T cells, the memory B cells produced in the body after natural infection that have been lasting up to 200 days. A recent article helped show that, which I think is fantastic. But are these antibodies actually able to prevent further infection is the question. Are they antibodies affecting the key component, the receptor binding domain of the spike protein? And I guess that's where, to answer the question, a bit of a winded response, is that yes, people who have been infected should still receive the vaccine. It's up to their doctors to talk to when that timing might be, but the answer is yes. Point three, even if COVID-19 doesn't make someone very sick, they could pass it on to someone else who might be more severely affected. And this is what we were seeing, I think, in the nursing home population early on. I had a number of cases, patients that would tell me that sick relatives would come home for Christmas and they would have mild infection. They didn't really make a big deal out of it, but they would infect everybody in the home. Some of them were very elderly, and there were some family members that were lost after these experiences. This all happened over the Christmas holiday, but I thought of that when I saw this particular point, that many people may not be very ill with COVID-19, but until it's run its course, they can be very infective to those around them. Last point, everyone should continue to wear a mask around others, wash their hands, practice physical distancing, even if someone gets the vaccine. So this is a key point, I think, that with all the variables that go along with the vaccination process, not knowing how long the antibodies last, not knowing if the individuals are developing neutralizing antibodies to interferons in their system, not knowing this process of immunosenescence in the elderly and how it might affect the vaccine response, that it's the first most important step, but other measures, especially in those who are immunocompromised, elderly, or at risk, should continue to abide by.
Absolutely. I think it's just better to be safe than sorry at this point. As the data comes out, we learn more. I would rather have been too cautious than not cautious enough. So I absolutely agree with that. So continuing on with dispelling some of those vaccine myths.
Yeah, so this is a popular point, one that has gotten a lot of attention. No evidence that COVID-19 vaccination caused any problems with pregnancy, including the development of placenta. So there's been a couple points looked at. Now we're seeing that pregnant women are safe to undergo vaccination. Pregnant women have a much higher complication rate if they're infected with COVID. Pregnant women have a much higher rate of preterm delivery if infected with COVID. And preterm would be earlier than 37 weeks. So the development of placenta abnormality has to do with a very remote protein within the placenta that looks genetically like a tiny protein on the virus. The thought that the body would develop an antibody against both of these proteins, it's somewhat ludicrous. It has no cross-reactivity and it's not been shown to, nor has any vaccine ever been shown to have problems with the placenta. So I think that is a concern that really has no scientific merit, but one that should be discussed with people if that's their fear, so they can really understand the science behind it. Point two, no evidence that fertility problems are a side effect of any vaccine. Excellent point. Never has a vaccine had an effect on fertility that we're aware of. That would include the current vaccines. And I would argue that actually the virus itself has more of an effect, and in the male population, because it can affect the male's organs, the scrotal region, that their fertility could be affected by being infected with the virus. COVID-19 vaccines do not change or interact with your DNA in any way. A key point to make, I think that is a myth that a lot of people seem to adhere to, but there really is nothing about the vaccine that would allow it to interact with your DNA. Many things can have an effect on DNA, not the vaccines for sure. And I think that's important to realize and for people to understand. Point four, the CDC cannot mandate that someone get a vaccine. Well, that of course is certainly true. Now, we may see government organizations, once full licensure for the vaccines are achieved, try to make that clear. I've read a lot of hospitals just this week that are trying to mandate people get the vaccine if you want to work in their hospital. I think they're waiting for the full licensure agreements to be passed, but as it stands now, this cannot take place. Last point, individuals will not test positive for COVID-19 on a viral test after getting a COVID-19 vaccine. So just for clarification on that point, the antibodies certainly may be positive, but a viral test, such as the nucleic acid amplification test, looking at the genetics of a virus, will never be positive after you get a vaccine. We're not giving individuals the virus, you see. So I think it's important for people to understand that this is not something that is going to have false positives in that regard.
Absolutely. And I wanted to just go back to the DNA myth, because I do think part of that stems from individuals not necessarily understanding the difference between DNA and RNA and the purposes and how that affected RNA versus DNA. And I think some education is really needed there. And so I do think that one still persists because of that. So I really appreciate everything that you've discussed here. You've touched on so many different topics and brought so many different things to light, and really great talking points for us ourselves as human beings, but also as clinicians with our patients and our clients, and moving forward, being able to help further educate and help ensure the safety of everyone, and moving forward, hopefully help reduce the transmission of COVID-19. So do you have any closing thoughts for our audience?
Well, Jackie, once again, thanks for having me on today. I think that just from the patients and the caregivers that I've taken care of, it's always important to, at least I found, to hit the myths head on, meaning I'm a big believer that people should be vaccinated. And if I have patients who choose not to, that is their right. They have that choice, certainly. But I usually try to understand why. And if it's something I can help them clarify further, I'm more than happy to do so. And I found in many situations that's truly the case, that there are people like anyone else. And these myths that we brought up today, if you don't really have somebody to talk to about them, how do you know if they're true or not? So, and there's data that we can refer them to if that's what they're interested in, articles that review a lot of these topics. So I guess my most important point is, if you have individuals who are not interested in a vaccine, I would talk with them first just to make sure that they understand what it is that is scaring them away. And many times it's issues that you can engage in conversation with and help them maybe see the science and the medical benefit behind it.
Absolutely, I totally agree. And thank you for helping us further think of and come up with ways to further educate our patients, and really encouraging all of us to moving forward to help reduce the transmission, and hopefully save as many individuals as possible from hospitalization or worse. So much appreciated. Thank you so much for your time today, and all of the discussions you've done previously on this topic have been just so informative. So in closing, we would like for you to be able to find more information on this topic and many others at PsychU.org. If you're interested in listening to some of those previous presentations that Dr. Pattee has done, or any other types of topics that we have on there, please feel free to go ahead and watch some of those that are have now been archived on there. Or if there are any presentations that you would like to have at your own facility or clinic, please feel free to reach out, and your local medical science liaison can work with you to bring those presentations to your clinic or facility. We do have an app that we recommend that you check out. You can access those webinars and live events. There's the resource library. There's a whole collection of psychiatric rating scales. And then there's also the patient caregiver corner. That is a great resource for your patients. Get your resources on the go. We also have the PsychU community podcast. I highly recommend that you check this out. Here we have the ability to talk about some of these really great hot topics in shorter snippets if you have less time, but you still want to keep up with the information. We spill the tea on so many different things on there. Thank you again for watching, and please stay tuned for part 3, where we'll have Dr. Pattee come back with Dr. Agarwal as the psychiatrist and Kathy Day from the patient caregiver corner to give their perspectives as the part 3 of this viruses, vaccines, and long-term consequences series. Thank you again, and have a great day.